nursies, welcome to the nurse aspect where we assess and evaluate. Today on the show we have Nurse Kaz. Welcome.
Hi, thanks for having me.
How you feeling?
Feeling good.
Good. You look good.
Thank you. I appreciate it.
Good. So tell me, why did you get into nursing?
You have a minute? No.
Plenty.
I don't know. I'm a people pleaser, I guess. So it's makes it easy, I guess. Like being a people pleaser makes it easy to be a nurse because I like helping people. But no, for a long time, I am a people pleaser, but that's not the reason I went into nursing. I had no idea what I wanted to do for a long time. I actually originally went to school for a very short semester for electrical engineering.
What?
Yeah, electrical engineering. Because I always loved computers, but I never loved computer programming.
Okay.
So I wanted my future to be in computers, but I wanted it to be on like the hardware side and not on the software side.
Okay.
So I wanted to like put things together, and I had done enough training in high school to like be able to put together computers. Don't ask me how to do it now because computers are completely different than they were 20 years ago, and I just don't remember how to do it anymore.
Okay.
Anyway, I got into electrical engineering and realized it was a lot of math. A lot of math.
So the high school math didn't help you with the math for engineering?
It could have if I actually paid attention to anything I was doing in high school.
Okay.
Yeah. But math is not my thing. Numbers are not my thing. Like nursing math is probably my limit. Like I enjoy nursing math. I actually enjoy nursing math, and I think it's super practical in real life because I can do a lot with the nursing math I learned in school with like random real life stuff.
Okay.
But it was not like the math that I wanted to do. It was all about putting circuits together and like figuring out formulas. Just wasn't my thing. And also like I was like 17 years old and I didn't know what responsibility was. So I was not responsible at all. Anyway, realized it wasn't my passion. Eventually I always like in the back of my mind wanted to do like creative writing. So I kind of wanted to be a teacher. I had some like memorable teachers in high school where they kind of felt like mentors to me a little bit. So I wanted to be like that for other people. So I kind of like slowly started working on like going into education. When you go into education, they make you take a bunch of broad classes. It's actually almost a lot like a liberal arts degree.
Okay.
But like the last few classes were actually like had to do with like the education system.
Okay.
And like it kind of like how do you say it? I always have problems with this word, but it basically like it turned me off to it because like it wasn't just like the fantasy in my head about like being that cool teacher in that movie or like that TV show. Like I realized just how much bureaucracy was behind all that.
Okay.
So that was even more of a turnoff. Eventually, I got my associates in it and moved on to a 4-year school. And I started taking like my first class. I was still doing part-time, so I was only really taking like 1 or 2 classes a semester. And I had also gotten a new job at this like small telemetry company, if you can call it. It was like a company that worked with doctors. They had the equipment for like portable loop monitors. So say a patient goes to their doctor for chest pain or palpitations, or they go to the ER for that, and they can't find anything. Blood tests are normal. Doctor can't find anything. So the doctor might prescribe them to the service where they wear the 30-day loop monitor or a 24-hour/48-hour Holter monitor. So I worked at this company. I would read the recordings they would send over, and I was just doing that while I was finishing up school. So then I started my first semester in the 4-year school, and at the same time I did that, that's when Hurricane Sandy happened. So that kind of like turned my life upside down. And when when we finally like recovered enough to like be back on our feet, I was just like, I just didn't have the energy for it anymore. I didn't have any passion for it. So I decided to just drop out and just focus on maybe trying to find a career in what I was doing. I had already had experience in it. I knew how to read EKGs. So I decided to stay where I was and see if I could move up that way. that didn't work out too well either. The longer I worked there, I realized it wasn't a very good company. They weren't treating their employees right. There was really no room for growth because it was just like a father-son kind of business.
Oh, like a small like mom and pop shop type of
Yeah,
thing.
mom and pop shop. I mean, yeah, if you can call it that. Yeah, but it's basically, yeah, mom and pop, basically. There was no
Okay.
room, unless they wanted to like bring you in as a partner for the business, you weren't
There's no
going.
room to
Yeah,
grow.
there's no room to grow.
Okay.
Not to mention the employers were borderline abusive, but that's another story. Anyway,
Okay.
yeah.
Yikes.
Not like they weren't taking like things
I mean,
and hitting me with them.
I mean, that's what it kind of sounded like. You said abusive
I mean,
in what sense?
abusive is like they wouldn't pay you on time.
Oh,
They would yell at you, scream at you.
That's a little egregious. Yeah.
They would scream at you. They would
Scream
yeah.
not at the mom and pop shop.
No, my boss was off the boat Italian, and that's all he knew how to do was scream.
Gotcha.
You know, he was verbally abusive and emotionally abusive.
Oh wow.
You know.
Okay.
Anyway, I got so sick and tired of working there that eventually, like, you ever just like rage apply to like different places? Yeah. So that's what I did. Maybe a week or two later, I get a call from a recruiter, and I'm like, no way! I can't believe this actually happened.
Mm-hmm.
So they called me back, and they got me an interview, and I didn't know where I was going to be working or where I was going to be interviewing for because it's a huge hospital.
Mm-hmm.
Because I know there are a bunch of telemetry floors in the hospital, but it's not like, you know, they're different floors. Nothing's good. Like, it's not one department. You know, that's I didn't know it worked like that back then.
Okay.
But anyway, so I think the day before my interview, the recruiter calls me and tells me it's going to be in the emergency room. I'm like, wow, that's crazy. I never thought I'd do something like that. That sounds pretty stressful. But I was excited. I was excited for it.
Mm-hmm.
So eventually I went to the emergency room. I had my interview. They interviewed me. And they gave me a test. I had to pass some sort of EKG test. So I did that. At the time, I was also volunteering at the firehouse by my house. So I kind of got like a little feel for being like hands-on with people. So it kind of got me interested in that. So I thought it was cool because I worked as a volunteer. I liked emergency stuff at the time. You wouldn't call me like a buff. You know what a buff is, right? I wasn't a buff, but like I was kind of like I was getting into that life a little bit. So like going to work at an emergency room is exciting. It's exciting for anybody that is into that kind of stuff.
Mm-hmm.
So I think that helped me with my interview there. Anyway, I got the job there. They were very happy to get me, and I ended up working evenings in the emergency room doing telemetry. At first, the telemetry hadn't been built. For the first 6 months to be working there, they trained me as a PCA. So, yeah, I got to work as a PCA in the emergency room, and I thought it was like one of the coolest experiences ever. I mean, it was like, yeah, I loved it.
What'd you like about it?
I liked that you never knew what you were going to see. Obviously, obviously you work there long enough, you know what you're going to see for the most part every day.
Mm-hmm.
But like everything was, I was brand new. So every day was like a brand new day to me. Like I never knew what I was going to see.
Kept it different. Kept it like on your toes.
It was fast paced, and honestly, my favorite part. It's gonna sound weird, but my favorite part was like all the teamwork you had to do with the people you worked with. Like it really like the sense of camaraderie that I felt. I don't know about anybody else, but I felt like a huge sense of camaraderie because you really have to work with people to like move patients in examining rooms, move them out of examining rooms, deal with emergencies that might show up. Like it's just like it brings people together. I guess now they call it trauma bonding. I learned a lot about myself and how to work under pressure. So I learned to adapt. And
so what made you like from there? Like how did you get into nursing from there?
Well, I knew that I loved the work I did as a PCA.
Okay.
And I knew that I loved EKGs. And I knew that there was no other way to move up unless you become a nurse. I wanted to move up. I wanted to make more money. So
it was a good driving force.
It was a good driving force, yeah. So I decided to go into nursing. I knew I didn't want to be an emergency nurse. Like I loved the work as a PCA there, but I don't think I could. I probably could survive there as a nurse, but it's a lot. It's a lot
Yeah.
to take on being an ED nurse,
Mm-hmm.
especially at the hospital, that I work at. Like it's a lot. You see a lot,
Yeah.
and I I hate getting a new patient. Like I don't know. I hate getting new patients
Mm-hmm.
because like I don't know. I hate reading through all their charts and studying everything and like making all these notes.
So working at a hospital where you do get patients, like how did you deal with that? You said you hate getting
Well,
patients.
no, what I was trying to say was that like I hate getting patients. I hate like coming in my second day
Mm-hmm.
and
And
get
getting
having a new
new
patient.
patients. Okay.
These nurses get patients like every hour
Mm-hmm.
and they get capped out at 8, you
Mm.
know? So like if I found getting a new patient the next day was frustrating, I can't imagine
Ain't
how
no
I'd
way.
be
Ain't no
deal
way you sitting in the
no way. Exactly.
ED.
Exactly. So
So
I knew being an ER nurse wasn't for me, especially because trauma wasn't my thing. My thing has always been cardiology. It's always been EKGs.
you got a
I've
strong
always
background in that.
yeah. I mean, I've always liked electrophysiology. I
Mm.
can't say like I'm a big fan of like the like vascular stuff, like coronary stuff, doing
Okay.
cath labs, but the electrical flow, like I love it. It's like dealing like with circuitry, but with like the human body,
Mm.
basically. So I always wanted to do something like that. Um, so, you know, I asked people around, and they said, that it's not just the emergency room that has fellowships. Other departments have fellowships too. Like you can go to CCU and do a fellowship there. So I said, okay, let's do that. Um, I knew I loved helping people. I knew I loved EKGs, and I wanted to take things further. So that's what I did. I went to school for nursing for that.
So where did you start in your nursing career? Like so now you went to school, you graduated, you have your degree now in nursing. Where did you start? Like in you said you mentioned cardiac. So where did you
Yeah.
start?
Um, so as much as I hated the emergency room, no, scratch that. I didn't hate the emergency. As much as I hated the thought of being an emergency room nurse,
Mm-hmm.
I wasn't against the idea of doing it just because of how much experience and value it adds to your CV.
Okay.
Um, so I had shown some interest in that. I reached out to people. I never really got anything back, even though I worked there for many years. I was like, all right, whatever. But as a teletech, at some point, my management, the people who managed me, uh, kind of outsourced me to the manager of one of the telemetry floors.
Okay.
Um, so because they did that, I had made a connection with that manager. So she knew that I was in nursing school, and we had a decent relationship. And I asked her, you think I can maybe get an interview after I finish school? And she said, yeah, sure. Just send me your resume when you're done.
Mm-hmm.
So I did that. I sent her my resume, got an interview.
Did you get the job?
What do you think?
I don't know.
Yes, I got the job.
All right.
Yeah, I
So.
got the job. Um, so I worked there. It was a telemetry floor,
Mm-hmm.
standard med surg telemetry,
Mm-hmm.
and I thought, I don't know if I thought it was going to be easy. I guess easy compared to the ER, but it wasn't easy. Um, there was a lot of stuff to work with, a lot of stuff to learn, a lot of stress to deal with, and a lot of stress to learn to be okay with. Not okay with, but a lot of stress that you have to realize that this is life now.
Yeah.
You know?
Yeah, I mean, I think that MedSurg will do that. Especially, I particularly found MedSurg Tele to be way harder than just regular MedSurg.
Yeah.
Like you have, and the type of telemetry unit that where we met,
Hmm.
obviously, is it's a lot. Almost every patient is being monitored. So there's a lot of things going on at the same time. The type of equipment that you're using, on top of balancing your patient load, on top of balancing family members, on top of balancing like medications, drips, and all these things and stuff like that. That you have to deal with. MedSurg Tele is not by any means easy at all. But it if you get through it, you definitely become a stronger nurse. That's for sure.
Yeah,
That's for sure. So
definitely.
what did you like about MedSurg Shirley? What did you hate about it?
What do I like about med-surg tele? Well, I can say that my experience with EKGs made things a lot more comfortable for me, or at
I
least
know
I
that's
thought it
right.
was going to be.
Okay.
Um, there was always this like misconception or myth or some type of viewpoint from teletext that um, no one cared about what you had to say. No one believed what you had to say. You were just there to record things and you know, show them to the doctors or tell the nurse. And you know, they don't believe you and they think you're dumb and you're always annoying. So when I came into this being as a nurse, I said to myself, well, now I'm a nurse. I can actually give my opinions on these EKGs and like it'll actually hold some weight.
Mm-hmm.
Girl, it was the opposite.
Mm-hmm.
It was the opposite.
Mm-hmm.
I remember like not agreeing with something a teletech had told me, and like the provider would still go to the teletech and take their word over mine.
Mm-hmm.
And I'm
A
like,
slap in
it
the
was
face.
eye opening. It was
Mm-hmm.
eye opening.
Yeah.
I couldn't believe it. I couldn't believe I'd spent all this time like getting excited for the fact that like I have a say in
Mm-hmm.
what's going on with my patient,
Mm-hmm.
but I didn't.
Yeah.
You know, it was really disheartening.
Yeah.
That was really
I'm not
disheartening.
gonna lie though, you are like were one of the best like teletech nurses ever. I feel like I would get a rhythm and I'm looking at I'm like, I don't know what I'm looking at. I'm like, guys, can you tell me
Oh,
like, you know,
stop.
what do you think or whatever? So I valued your impact and as did a lot of people on the floor.
I'm sure they
But
did. Yeah, I'm sure.
yeah, I mean, it's definitely, you know, coming from one side of the fence to the other, jumping into nursing. And, you know, yeah, I'm not even surprised because like, you know, everybody always, you know, feels like, okay, teletech, you've been doing this, you know, and versus a nurse that's coming into med surg tele, like, and especially if they don't know you, they're not exactly going to take your word over it, unfortunately. But yeah,
Yeah. It was just very eye opening. It was
yeah.
very weird. It was very weird. Yeah, I remember. I remember I had a situation where I had a patient that was going into SVT or atrial tach, and I had to deal with the problem all night.
Mm-hmm.
And the teletech kept saying it's sinus tach, and it was like it was driving me nuts because it wasn't sinus tach. And like I kept trying to tell the provider, listen, if the patient had a gradual increase in heart rate over the course of like an hour, say they started at 80, 8 o'clock at night, and then gradually went to 90, and then gradually went to 100, and then gradually went to 110, and now we're at 2 in the morning and it's 130 sustaining, I'll agree with you that it's sinus tach. But when you have someone that's going, that has a heart rate, normal sinus rhythm going into like 70 beats per minute, and then all of a sudden, out of nowhere, no warning, you pop into the 130s. That's a dysrhythmia you have there. That's something that's it's not sinus tach. All right, it's just not. You need a gradual increase in heart rate for sinus tach. If it's just like a paroxysmal start out of nowhere, it's either some type of atrial dysrhythmia or some type of SVT. That's how I've always understood it. Okay.
And nurse cause dropping knowledge for med surg teletechs out
Oh
there,
my
med
God.
surg nurses out there.
Always, like, don't take my word for it. Always research some type of scholarly source. Okay. Don't just take my word for it. But I'm fairly certain I'm right on this one.
Oh yes, do your research, but also what you're saying is true. It's facts on facts.
Facts.
So, where are you now? Are you still med surg tele? What are you doing now?
No, I'm not med surg tele anymore. I always wanted to do critical care,
Okay.
just because my dream has been to work in EP lab. I always wanted to be an NP for EP, solely based on the fact that when I was in the ER, I would always see them come down to consult patients, and they would always roll around this machine that looked. Remember in high school where like the projectors in
Yeah,
high
you
school?
excited to see it.
Yeah,
Yeah.
they were like they looked like projectors in high
Yeah.
school, right? But these machines were actually like devices that would interrogate people's pacemakers. I don't know if you've ever seen it before. So they can like, I guess through Bluetooth or some type of wireless access, they can just bring the machine within proximity of the patient and turn it on, and they can check the settings. They can look at what the pacemaker is recorded. I don't know. I don't know how far back a patient's pacemaker can actually record throughout the day, but I imagine there's some type of like storage. I don't know exactly how much it is, but anyway, you can go back and see throughout the day, maybe 24 hours or something like that.
Okay.
You can go back and see if the patient had any events. You can check the battery like how I used to do with the old pacemakers. What else can you do? You can change the settings, all wirelessly. So I always thought that was the coolest thing in the world, just because if I knew there was an interrogation that was about to happen, if I saw on the monitor, like all these weird and wacky things would happen. I just thought it was the coolest thing in the world, and I really, really, really wanted to do it. I don't know if I'll still do it, but the dream is still to eventually work in electrophysiology. But anyway,
What's EP for those people that don't know what EP is? What is EP?
Electrophysiology, EP lab. So people get ablations there. They get pacemakers, defibrillators, anything that has to do with the electricity of the heart, basically. Okay. I'm sure I'm missing some stuff. I still really want to shadow there at some point, but that's basically what they do. Cardioversions, ablations, pacemakers, defibrillators, loop recorders, stuff like that.
Okay.
So I used to talk to a lot of the EPNPs that would come and look at the strips that I had in the ER tele room, and I would ask them about it, and they told me that you needed to have like 2 years of critical care experience. Okay. I don't know if that's like solid criteria or not, but that's just always what I wanted to work towards, because, you know, like, yeah, I had experience in the ER doing tele, but it wasn't nursing experience. Right. So, like, yeah, I'm sure it would hold some weight. I'm sure that might impress somebody on a panel of interviewees, but if they hear that I don't have any critical care experience or, like, any cardiac experience, then, like, they're probably not going to get the job.
So what are you doing now?
Oh, so now I work in the PACU. So I know it's far from cardiology because we don't get a lot of cardiac cases there, but I get to see a fair amount of critical care stuff. Like I see a lot of A-lines there. We see people on Precedex drips. We see people on Neo drips. Sometimes we hold people that are supposed to go to the ICU, but there are no beds in the ICU, so they'll stay in the PACU overnight. Like specifically like NSCU patients that need to be like frequent neural checks like hourly. We'll have vented patients there. I've only really seen like one or two. That's not really something that's common, but it's not like full on ICU critical care experience, but it's not bad. You know, you get to see some stuff, and the workload is a lot less stressful. Yeah, granted, you have your own type of stress there. Being able
less
to
stressful than med-surg tele?
Yes.
Okay.
Yes, 100%.
Okay.
1,000%.
Okay.
You know, you talk to most people that work, and most nurses you talk to, especially most veteran nurses you talk to. You mentioned the PACU, that they kind of see it as like the retirement. You go there to retire. Yeah.
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 I always felt like I always hear like endo would be like that, or like outpatient, something like that would be like more retirement. I didn't know PACU was.
PACU is considered, at least in our place, in our hospital, PACU is considered retirement.
Okay.
I knew a ton of ER nurses that went to PACU because they were just burnt out from the ER. And going from ER to PACU is great in most ways because you kind of get, it's kind of like the same workflow to an extent, because you're still getting, like, you'll still get multiple patients over the course of 12 hours, but like on a busy day, you'll get like 5 total.
Okay.
Right.
So because what you said earlier in terms of like getting new patients on the second day, being the PACU doesn't bother you?
No, I mean, I knew going into that was going to be the case.
Okay.
So like, how can I complain about something that I know that I'm getting into? Like, I can't complain. I knew it was going to be a thing, but it's really not that terrible. Like, is it like annoying to get a brand new patient? Of course. Like, but like, it's fine. It's fine. It's really fine.
Okay.
As opposed to getting like, it's as opposed to like maintaining a patient load of 8 patients throughout the day. And not only that, and I'm not talking about med surg tele, I'm talking about the ER.
Okay.
Right. Like getting new patients, like a patient every hour, basically.
Yeah.
And staying at 8, like that to me that is stressful.
There's no break.
Yeah, there's no break. So, like that's fine because on like from what I've seen on a normal day, I might get like 3 patients in 12 hours.
Okay.
But you have to do different things for these people. Like there's a reason you get 3 patients in 12 hours because you're working on recovering them, making sure they're pain free, and then getting them home or going upstairs. So it's going to take like 2 or 3 hours per patient on average. Sometimes you'll have someone that's there like only an hour, and sometimes you'll have someone there that's either there for 5 hours or they're there for 6 hours because of like post-op requirements, or 5 hours because they're supposed to go home but they're taking forever to recover from anesthesia, which happens, depends on the patient, depends on their body. So yeah. It really can take quite a while to recover a patient and send them back. That's why you might only have like 3 patients throughout the day or 5 patients.
What's like one of the things you love about PACU? If you can narrow it down to one.
Well, I'm finishing up 2 weeks of vacation, and I still have.
I'm not gonna lie. I was looking at your nurse grid like.
You saw it, right?
You don't work.
I don't work.
You clearly don't work. Like I'm looking at them like it's a lot of empty boxes here. Like you have 4 days for the month. Like, are you part-time? It's given you're like not a 1.0. Like
it feels that way. It feels that way.
Yeah. Because that's not happening in med-surg tele.
Yeah, I do love that a lot about PACU, but that is not the thing I love the most about PACU.
Okay.
I would say the thing I love the most about PACU, I don't know if this sounds selfish or not, but like people are super grateful when you help them recover from surgery and procedures, and like you really get to see the impact of what you do more when you're working there, as opposed to feeling like you have a thankless job in the emergency room because people are coming in and out so quickly.
Yeah.
They're all upset. They're all frustrated. They're all feeling like garbage. They're all in pain. So there's no time to thank you. They just want their sandwich, and they want you to give them pain medications, and that's it.
Yeah.
But like with PACU, like you give them pain medications, you let them sit there for a couple hours, you let them recover, you help them walk to the bathroom, you make them feel comfortable and at home, and not to feel like bad about needing help. I don't know. I felt the gratitude a lot more, and it helps me want to come back to work.
Okay. Is there anything you don't like about PACU?
Sure. What is it that I don't like the most about PACU?
That's kind of a
yeah.
good sign.
I have to. I have to
sign.
actually think about it.
Wow, ladies and gentlemen, go to PACU.
Yeah.
That's
Go to PACU. No. Look, it has its own fair share of stress.
Of course, yeah, I'm sure.
I guess the thing I don't like the most about PACU is that when you have those busy days, at least for me, because I haven't been working there too long, sometimes you just finish getting like a busy case out of there and like next one. Sometimes on like a super busy day.
Okay.
That's probably the most frustrating thing about it, because sometimes it's the downtime is so sporadic. Like sometimes you'll have like 2 hours when you're like doing pretty much nothing, and then you'll have times where you're literally spending all your time with this one patient, and then by the time you finally get them out of there, it's time to get your next patient, and there's no time to breathe.
Okay.
That's what it feels like to me. Everyone else there seems to say like this is the easiest job in the world that they ever have, and for the most part, I agree with them. It's a fairly comfortable job, and I feel like there are a lot of misconceptions out there that PACU is like just a walk in the park. I wouldn't say it's a walk in the park. There's definitely a good amount of work that you need to do, and there's definitely a lot of caution you have to take with your patients. You know, you're giving out a lot of pain medications. You're taking care of a lot of people that have anesthetics given to them, which lowers blood pressures, and you're giving a lot of pain medication, which lowers blood pressures. And sometimes you get patients that have the anesthetics and the pain medications, and on top of that, they also have low cardiac output and low EF.
Yeah.
So you can have even lower blood pressures. Like, you know, it gets kind of stressful sometimes. I mean, we also deal with a lot of kidney transplants, you know? So, you know, there is risk there.
Yeah.
I remember seeing this TikTok of this guy being like, top 5 easiest nursing jobs. Oh, PACU, you just give people applesauce and cookies and let them go. That's it. And you get paid. And I'm like, that is
The furthest thing.
that is a gross exaggeration of these, like a gross simplification of the job.
Yeah.
You know, so that's my biggest pet peeve with the misconceptions about PACU.
Okay. Did you find that it was easy for you to get into PACU, like coming from med surg, like in terms of like, did you have a connection, or you just was just like, I'm just going to shoot my shot and apply? Like, what was that process like for you? Did you have a way in or no? Besides, like, obviously working at the hospital.
Yeah. Yeah, I knew people.
Okay. You did? I didn't know that. Okay.
Some people. I mean, you work in the hospital 10
I mean,
years. You meet some people.
but like,
you know?
I know, but like, you know, I didn't know like that.
I didn't have
like,
big connections, but like, all right, I'll break it down for you.
Okay.
I knew a PCA that I used to work with in the ED. She got burnt out, so she moved to same day admissions.
Okay.
She overheard that there was going to be a very first PACU fellowship in the PACU and the SDA, that there was going to be cross-training between PACU and the SDA, and then she thought that I should apply for it. It wasn't really where I wanted to go, but I was kind of hitting a dead end with wanting to get into critical care and ICUs. So I was like, yeah, I'll just shoot my shot. Why not? Had I not known that PCA, I would have never have known that there was even a fellowship going on. So, yeah, I mean, I heard from other people about this, and it's not like I knew the directors and I was like good friends with them or anything like that. So
I feel like that's a good nursing tip. Like it's always good to be nice to your PCAs.
Yes.
And also like it's good to always make connections. You never know where your next connection is coming from. Right. And also what's for you will always be for you. Like you put your resume in and you didn't hear nothing, but that spot was always going to be for you. Like, you know, do you feel like working in PACU will help you in terms of EP? Like does that time help at all, or do you have to be in like critical care, like an ICU?
So I think that, like I said, I don't know if it's like a hard criteria that you need 2 years of ICU experience, right? And yes, PACU isn't like the most critical of critical care backgrounds, but if PACU is not enough, I will go somewhere else and do what is enough. But I don't know. I think so. I think it should be enough to show that I have like some critical care experience. Also, on top of my, you know, almost 10-year experience with EKGs and telemetry, on top of doing 2 years in med surg tele, I think that gives me...
You have a decorated background.
Yeah, I think I have enough of it.
Yeah, you qualify.
Yeah, I think I'm qualified enough to be able to like be a runner-up.
Okay. Don't worry, we'll check back in at some point and see like where you're at. Like, all right, NPEP.
Oh God, I can't even think about going for a master's right now. I mean, yes, I can. I'm getting to the point where I'm starting to wonder: is it time to go for the master's? Because I mean, it was always part of the plan.
Yeah.
I just didn't know when it was going to be.
Like I said, what's for you will always be for you.
Yeah, we'll see.
Okay,
we'll see.
That was great. Thanks for sharing.
Yeah.
So now we get into the part of the show that we call the Nurse's Note. Nurse's Note is where we document our experience in terms of what we do in nursing. As nurses, we always have to document. We have to chart what happens, what we deal with our patients. And so I wanted to create a part of the show where we share our own experiences. So Kaz.
I
What
go
is your
first.
note?
My note. Okay. I guess my note is that you'd be surprised by how much your patients notice and how much they appreciate what you do for them. I have an experience where we had this little lady that got admitted to our floor, and forgive me, it's been like probably a year since I had her as a patient, so I don't remember exactly what her case was. I know there was definitely something to do with sepsis, and she had some type of CKD. So she wasn't English speaking, and I had to communicate with her through the translator phone. I did my initial like interaction with her. I introduced myself. I gave her all the basics upon first time seeing her. So I didn't use the interpreter after that unless there was something that like there was a serious medical decision that needed to be made.
Hmm.
So we kind of like had this understanding with each other. We'd say hello to each other, and she was able to get her needs known without really needing to use the interpreter every 5 minutes. Eventually, it came to the point like because she had the CKD, her blood count was low, so she needed a blood transfusion. But she also had heart failure as well, so we had to do that whole like half unit thing. You give a half unit, then you reassess the patient, give the other half unit after that. So it was just a long process. So that was something I definitely had to get the interpreter phone for her. So I used the interpreter and I explained the whole situation to her. And usually when I use the interpreter, I ask the patient, is there anything else you'd like to ask before I hang up with the interpreter? It's a good opportunity to get whatever needs they need out of the way, and they haven't been communicating to me. So I ask her this. She goes to the interpreter and she says, I'd like to take this moment to just really thank you for everything you've done for me. You've had to do a lot of things that I would find disgusting myself, a lot of hard things that not a lot of people are able to do. And you've taken such good care of me. So I just wanted to say thank you. And it was a little longer and more heartfelt than that, but it was like it completely took me by surprise. So I couldn't hold back tears. Like I started crying when I said thank you. And it just made me realize that like, she doesn't speak English. She's very quiet. She's not a very difficult patient. She kind of just sits there and she watches. But I mean, she noticed everything I did for her and she really appreciated it. And hearing those things from her, like it like I kind of needed that like as like a renewal of faith and like knowing that I picked the right job.
Yeah.
The right career.
That's great. I feel like I need a little tissue. A nurse aspect tissue. That's what I need.
Oh yeah, there you go. You should get little boxes that say nurse aspect, like little tissue boxes.
I should. Coming up, maybe next episode. We'll see. But that's really good. I feel like, as nurses, depending on where you work, a lot of times it can be a thankless job, just like you said in the ED, med surge a lot. Like you don't have people that thank you as often, and definitely in certain specialties, you for sure see that like PACU, labor and delivery, you see that like those things, like it's almost like it's like life, even palliative, you see like, it's more like you have more of an interaction with your patient as opposed to having a lot of patients. And so they do take the time to thank you. And sometimes it reminds you of how important you are to your patient. And I wish it would happen more.
Yeah,
more
you don't
so
get to see it.
Yeah, you
don't.
don't. And so, yeah, it does mean a lot, especially if she's not English speaking at all. Like that's very touching.
Yeah, it is.
Yeah.
It really it brought a tear. I mean, look, it's not hard to make me cry, but like it brought a tear to my eye. I was emotional.
Yeah, that's very sweet. That's very sweet. To that patient out there, thank you. Thank you. Do you have any nursing tips of the day? Anything that you could, if you wanted to tell yourself something along your journey, or anything that you would tell yourself now or future, Kaz?
I mean, if there are any new nurses or nurses about to be brand new nurses listening to this, I can tell you things that I wish I had heard on orientation. Always have a pen on you. Always have a scissor with you because you never know what you're going to have to cut. Always bring a pill cutter with you because, I mean, I was shocked. As soon as I got off orientation, everyone needed half doses of everything that we had on the floor.
And pharmacy does not cut everything, let me tell you.
No, they don't. No. And then I'll give you one more. This is also for brand new nurses. I mean, it goes really for any nurse. Maybe some nurses need to hear it a second time, but I mean, when you're starting out, I mean, your assessments are your bread and butter. You really have to get comfortable with taking time to do your assessments on your patient, because it's gonna save someone's life one day. And if you don't do it right, it might not save someone's life when you could have saved someone's life. Bedside report, also another important one.
3 tips.
Well, no, that's part of the second tip, because bedside report's like part of your assessment.
2 for the person when I'm not mad at it.
Yeah.
That's a great tip, though. Definitely, for sure. Pens, woo. Pens for sure. Pen thieves are out there. Watch out for the pen thieves. But yeah, great tips, though. I love it.
Thank you.
Thank you for being on the nurse aspect.
Yeah, thanks for having me.
I love how we assessed and evaluated your path, and you're important. We'll check back and see how long it's going to take you to become a
let's fast forward a few years.
I don't have to listen. We have all the time in the world, I guess, but
yeah, I know what you mean.
We'll see. I hope that I do see, because we gotta spend that money also. Come support and buy me equipment and whatever, all the things that I need. Forget everything else in your life. I'm more important.
Tell that to my fiance.
Hey girl, I love you. But thanks for being on the show. Appreciate
No problem.
you.
Thanks for having me.